Probably just give a couple more minutes for people to join and then I'll get started. If that's okay. All right, probably go ahead and get started and then hopefully more people will join along the way. But my name is Nicole Gibbs. I am one of the ACVNU residents and currently at Purdue University. And today I wanted to talk about this article that came out fairly recently that talks about radiation therapy for urothelial carcinoma with obstruction. So this is the article. It's out of the Journal of Veterinary Internal Medicine, and it was, as I mentioned, published pretty recently, so in 2026, looking at how radiation therapy can be used for patients with urothelial carcinoma that have urinary obstruction. And this was particularly out of Colorado State University. So what we'll talk about today, so I did a little bit of a literature review for radiation therapy for urothelial carcinoma. Then I'll go into this article, talk about what their methods and materials were, talk about some of their major results, talk about some key points, limitations of the study, and then hopefully have some discussion about what you have been doing, if you've been doing this in your practice, or any thoughts you have on the article. But first, let's start with the literature review. So I think as most people or all of the people that know on here, kind of the current treatments that we talk about for urothelial carcinoma in dogs is kind of nonsteroidal anti-inflammatories, which are usually used in a combination or alone in palliative treatment. Chemotherapy, which there are a number of options that are utilized, probably some of the most common are mitoxantrone, vinblastine, and carboplatin, but there is like chlorambucil and many other chemotherapies have been reported with this disease. Surgery is reported mainly for the ones that are apical, so they are more easily removed, as opposed to the trigonal, which is the more common presentation of it. So surgery is largely largely not utilized for our patients just because the majority of them do have trigonal disease. And then radiation therapy, which is a more recent addition than things like chemotherapy and nonsteroidals, has been being used more commonly with this disease. And then when we think about relieving urinary obstruction, a lot of times we're talking about temporary stents, which could be like a red rubber stent, or the more classic permanent stents that are used, but also have been reports or uses of the resectoscope, so using electrocautery to dissect around the area to try and help open the lumen of the urethra, and also has been some reports of laser ablation of some of the tumors to try and help relieve obstruction. All right, so I'll dive into now. The main part of this background is going to be talking about radiation therapy for urothelial carcinoma. If you're at Let's, this was probably a lot of a review for you since there was a good talk on that. But One of the first articles that came out was in 2012 in JVIM again, talking about just the use of it in genitourinary carcinoma. So it included kind of prostatic carcinomas and urothelial carcinomas, and it was looking at about 21 dogs. They use definitive intent, intensity modulated or image guided radiation therapy, and their overall dose was delivered in 20 fractions given daily for a total dose of 54 to 58 gray. The response rate was reported to be around 60%, and then the time to event-free survival, which is like the time before they notice progression of the disease or metastasis or other complications that happen, was around 317 days, with the median survival time overall being 654 days. So a very good response seen initially with this, and this is just using radiation therapy in these patients. They did notice that there were some acute adverse effects, with about a third of the patients getting GI adverse effects, 10% having the genitourinary, which is like cystitis and hematuria, and then 20% having some skin adverse effects of radiation therapy. And then when they looked at late stage effects, only 4 of them had that out of the 21, with 3 of them being gastrointestinal and 1 of them being genitourinary. However, they did also notice that about a third of these patients, when they did have progression, it was local disease progression as opposed to metastasis, that ultimately led to them either needed to change protocols or, lack of response and euthanasia for these patients. This is one that was a more recent publication. So this one's 2021, where they were looking at the combination of using NSAIDs, mitoxantrone, and radiation therapy together to see if we can better treat them with a more global approach. Similar to the first study from 2012, they did 20 fractions. It was a definitive intent radiation, and overall they did 57 grays, very similar to the last study. They had 3 different treatment groups where they looked at patients that got chemotherapy and radiation therapy at the same time, which they said is within 1 month of radiation therapy. The second group was that they used chemotherapy initially and then started radiation therapy before there was signs of progression. And then the third group was radiation therapy as a salvage. So after they had received mitoxantrone and their NSAIDs, but they noticed progression, they would do radiation therapy at that time for that group. And they found that their event-free survival was around 260 days, and their overall survival was 510 days. So a little bit less than what was previously reported in the 2012, where it was over 600 days of overall survival, but still a very decent survival, especially compared to chemotherapy or NSAIDs alone. But didn't necessarily dramatically increase it from radiation therapy that was previously reported. They did notice in this study that dogs that had moderate to severe clinical signs did have a shorter survival, and they noted that if there was prostatic involvement, the overall survival time was also shorter in these patients. This study also reported incontinence after radiation therapy, with about 21% or 20% having incontinence that started about 70 days after RT. So about 2 months after RT, about a fifth of them would start developing incontinence. There's no mention in this article that I could find of any severity of that incontinence and like what that looked like for that patient. So this is just a different way of representing it, but this is looking at event-free survival and overall survival time. And so in the event-free survival, group 1 is the concurrent chemotherapy with radiation therapy. Group 2 is the first-line chemotherapy and then radiation therapy before progression. And then group 3 was the radiation therapy as a salvage. and 0.0, like, so the start of this was not radiation therapy, but instead it was like when they were first diagnosed with it. So you can see that there's a lot of overlap between these, and they didn't mention any overall significance between these groups. In general, it looks like group 3 just like subjectively looks like they did fairly well, even though they had previously, those are the ones that had progressed before they started radiation therapy. So I thought that was overall interesting, but not statistically significant. So when we're thinking about radiation therapy for urothelial carcinoma, I am just not as familiar with radiation therapy, so I wanted to do a little bit of a dive on like why there would be local treatment failure, since they noticed about a third of the patients in the 2012 study did have local progression after radiation therapy happened. And one of those reasons is that there can be radio-resistant tumor clones. So this could be because of a hypoxic tumor microenvironment. It could be that they have genetic mutations that's preventing this, or altered signaling pathways, all making them more resistant to radiation. Or if they have like an abnormal response to damage. So if they were damaged, but they still survive and proliferate, they may be radio-resistant as well. Another potential cause is field cancerization, and this is just where there's like mutated cells in areas adjacent to the primary tumor that appear normal histologically, so we would call them like normal or outside the tumor range, but they have some characteristics that can lead to treatment failure. And then the last one is geographic miss. So if we didn't radiate or irradiate the areas that had tumor, such as like if it was microscopic and we didn't see it on CT or cystoscopy, but that led to local progressive, that would be considered a geographic miss. So any of these three reasons could be why there is local progression with radiation therapy for a urothelial carcinoma, even with definitive intent. So to help with the geographic miss characteristics, there's this study that came out that looked at using cystoscopy before performing radiation therapy and see if that could help with these geographic misses that were considered. In people, cystoscopy is the main method for diagnosis and staging of the inhuman. So they use this in all of their patients that have urothelial carcinoma. And we wanted to consider the value of this for radiation therapy. So what they did was they had all of these patients that they were going to undergo radiation therapy, and they looked at what their CT looked at and what they would be calling the abnormal or the gross tumor volume. And then they also had those patients undergo a cystoscopy and measure where the abnormal tissue was visualized. So they would scope the animal, kind of start moving their scope from the level of the mass to where it is where it's normal. They kind of keep their fingers at the end, either at the vulva or on the prepuce, remove the scope to the abnormal position, and then measure that to know like how long the abnormal area is within the urethra. And so this is kind of what that visualization would be. So they looked at what the gross tumor volume was on CT alone. And that was, in this picture, is the red here. So based on CT alone, they thought the only area with urothelial carcinoma was within this red location. However, when they did cystoscopy on this particular one and for several others, they noticed that this area in yellow, or orangish yellow, here all had abnormal findings on cystoscopy consistent with like the urothelial carcinoma being in that region. And so they called that the gross tumor volume expanded because it expanded their original length. So based on this, they found that doing cystoscopy did lead to expansion of their region that they would treat in about like half of cases. And most of them were distally expanded. However, there was one that had prostatic tumor that did go proximally into the trigone. When they looked at how much expansion there was, it was about 6.5 centimeters, so quite significant into the urethra was what was missed previously. And if they kind of normal radiation therapy, it seems like they do expand what they see from CT by about 2 centimeters on each side to account for like changes in patient positioning or just the fact that there is microscopic disease in that area. And so usually 2 centimeters is what they add to their gross tumor volume to get their overall measurement for what they're going to treat. And if they had used just that and didn't have cystoscopy, there would have been an 83% would have a geographic miss, likely leading to then recurrence, local progression of this disease despite radiation therapy. And so this is just visualized a different way. So male dogs did have an increased amount of like geographic miss, or more of their urethra was affected than was usually identified on CT alone. So the median change was around 20%. Or was around 25%. Females had an increase of about 10% with the median here. So that about 10% of the urethral length was increased or had disease that was not identified previously. So that was kind of an argument to use cystoscopy with radiation therapy, or they also stated that if you weren't going to do cystoscopy, could consider treating the entire urethra due to the risk of missing that disease in that area and then having this geographic miss that leads to progression. For radiation therapy, also there are some toxicities that can occur with these, and there's 2 grading scales, TR or VR, TOG, and then there's the 2.0 version of this. So this was the initial one, and you can see it for like things like genital urinary. There's just saying like there's an increased frequency of urination, that needs medication, or if there's gross hematuria or obstruction, that was kind of a grade 3 for this. There's also characterized as like skin changes that happen with acute radiation effects. This is the same one, so this is the 1.0 or the first version of this still, and this describes the late effects that can happen. So if they have chronic microscopic hematuria all the way to like a contracted bladder due to fibrosis. Then they use the 2.0 design for this, and really just became much more descriptive about like what their baseline is, what those changes are to have a better range of what abnormalities we can see. So many of the patients that get radiation therapy for urothelial carcinoma will have skin, GI, or urinary issues afterwards if they do have effects from it. And so the GI ones range from just like intermittent diarrhea that they don't need to be medicated for or don't need hospitalized, all the way to, well, death is grade 5 in all of these. But can be like fistulas forming or strictures forming in the chronic stage. So this is just to give people an idea and a reference of what toxicities happen and what those grades could be for these patients, because that will come up later and when we talk about this current study. When we look at toxicity, though, this was another study that looked at overall survival, which was around 305 days, so less than what was previously reported. Time point of progression was 237 days after starting radiation therapy. About a quarter of them had tumor progression leading to death, so similar to about the 1/3 that was seen in the 2012 one, and a lot of them had acute self-limiting toxicity, but they did note that there was some late toxicities. And if you can see, they were like comparing these 2 grading systems, and the second grading system that had more of the categories did capture more of the patients that had abnormalities, and so late toxicity actually occurred in about 43%. If you can imagine, these are incontinent or they have like plaquuria as signs of toxicity. And that is obviously very difficult to distinguish from progression of urothelial carcinoma in general. So something to keep in mind that these toxicities are reported, but it just might be very difficult to tell whether this is due to radiation therapy itself or from their underlying disease process. So that's a background on radiation therapy for urothelial carcinoma. So now I'm going to talk about the study that I chose for this. So it's using radiation therapy for urinary obstruction in dogs that have urothelial carcinoma. So the cases that they had, as their title would imply, is that they had to have either suspected or confirmed urothelial carcinomas and had to have a urinary outflow obstruction. They had a wide range of years, so 2006 to 2023, and their inclusion criteria was that they had to have clinical signs of blockage, such as stranduria or not producing urine, colacuria, and overflow incontinence, so they just had to have some of the clinical signs. They had to have complete or partial blockage via cystoscopy, abdominal ultrasound, or CT. And then they had to have treatment with radiotherapy before any surgical intervention was done to relieve the obstruction, because they wanted to look at whether it can be utilized to relieve these obstructions. So note, I thought it's kind of interesting the way they denoted that this was a partial or complete obstruction. They did include both ureteral and urethral obstruction, which is probably where some of the ultrasound and CT findings could be helpful. But I do think usually we make this more of a clinical diagnosis of a patient being obstructed and like watching them urinate and seeing what their residual volume is, as opposed to using like imaging in and of itself to denote this. But we can talk about that later in the limitations. For case selection, as I mentioned, they include both ureteral and urethral obstruction, or if they were the unlucky ones that have both obstruction. And then they would talk about whether that was diagnosed on cystoscopy, ultrasound, or CT. And then they also group them, and this is probably kind of the more relevant as we go on, they group them by what treatment type they got, whether they received palliative radiation or definitive intent. And this was defined by the amount of gray per fraction they received. So definitive intent is lower gray per fraction, and palliative is the higher gray per fraction. So greater than or equal to 4 would be a palliative intent. They did degrade these adverse events using that scale we talked about earlier and the 2.0 version of it, so a little bit more specific. If it was classified as acute, if it was before or within 90 days of treatment, and a late effect if it was after 90 days. And then they did do, it was noted that the treatment planning and dose was not standardized for these patients. For the radiation therapy itself, CT was used for radiation planning in most cases. They used some reconstructed images and defined like the gross tumor volume, what their clinical target was. So this is the +2 centimeters. And then their planning target volume, which is kind of what they take into account, what the position, the shape, and the size of their targets are and how that can change over time. They contoured the radiation to organs at risk, so trying to avoid the colon, femoral head, cauda equina, and then the kidneys. And their goal was to deliver 95% of the prescription to 100% of the planned target volume. And they used quality assurance using a conformity index. They did have, so that was all for the more image-guided techniques. They did also have manually calculated treatments used in the palliative approach, where they used abdominal radiographs and then verified it using like the MV port film, which basically just means that they verified that treatment area matches the planned area before they delivered it. And then they would deliver it to the bladder and most of the urethra in those cases. So this was their quality assurance using the conformity index. I'm not very aware of the radiation therapy and how this is all calculated and performed and what would be considered good on this. So, and there wasn't that much of an explanation in the article, but they didn't particularly mention that it was outside of what they would expect. But you can see there was a wide range of what was done here, with the image-guided ones, the IMRT, having the better conformity index. So their follow-up, they looked at the time to when they relieved the obstruction from medical records using owner-reported relief, normalization of post-renal azotemia, and like recheck appointments to try to determine when it happened. They talked about any events or adverse effects that happened after RT, the date of death and the cause of death, and if they were lost to follow-up or alive when this was being analyzed, they were censored at that time. They weren't able to control for looking at response, which is the RECIST, which is Response Evaluation Criteria in Solid Tumors, acronyms for these, but they weren't able to do that to determine like response rate in these patients. For statistics, they looked at survival time, and it was calculated from when they first received radiation therapy. They looked at the events, so event-free survival, which is before they had local disease progression, metastasis, recurrence of signs, or death. And then they also, so they did Kaplan-Meier survival time. They also looked at the impact of tumor location and treatment intent on survival and obstruction duration. And then they were trying to determine if the location of the disease mainly affected whether they were able to relieve the obstruction. And they set their p-value at less than 0.05. All right, so now I'll actually talk about the results for this. So for overall, they had treated about 180 dogs with radiation therapy for urothelial carcinoma. 31 dogs met their inclusion, but 6 had surgical intervention before radiation therapy, and so only 25 dogs were utilized in this study. They had signs for about 16 days prior to being presented. And of these dogs, about 44% had a temporary urinary catheter placed before or at the time of radiation therapy due to obstruction. When they looked at male dogs, 44% had prostate involvement, and 1 did have an external compressive obstruction. And when I looked back at their imaging for these, only about 39% had cystoscopy performed as part of their workup and to determine their margins that they needed for radiation. So most of the dogs, 3/4, received NSAIDs before or with radiation therapy. 60% received radiation and chemotherapy together, some before and some after radiation was completed. There was a large variety of chemo protocols, so this was not standardized for chemo. And then they had 2 offerings. They had definitive intent, which had the minority of dogs, about 1/4 of the dogs had definitive intent, and 3/4 were palliative intent. And again, these all had various protocols. So the palliative intent had multiple ways of which they did imaging or multiple ways of which they delivered certain fractions to these animals. The definitive intent was a little bit more standardized in their approach. So the number that actually did get relief of their urinary obstruction was 60% overall. So that's seen up here. So 60% became unobstructed with radiation therapy, either with NSAID or their chemotherapy can be included in that as well. And they looked at whether BRAF made a difference and did not find that it was a significant factor in an obstruction. And then they looked at whether definitive or palliative intent was more likely to unobstruct them. And about 83% of the patients that had definitive intent did become unobstructed, compared to about 50% of the ones that received palliative intent. So definitive intent was able to unobstruct more dogs than, or a higher percentage than the palliative intent. After relief of obstruction, or when they were looking at this, they also looked at whether azotemia, the degree of azotemia before the treatment would have had a difference in obstruction, and it did not. 45% of the dogs that were azotemic at time of presentation did have an obstruction with radiation therapy. They did make a weird comment that 40% had resolution of azotemia using a post-RT urinalysis. I'm not sure if that was just like a mistake and they meant like on blood work or what exactly they were talking about for that, but about 45% will resolve either their azotemia or become obstructed. For the next part, when they looked at dogs that had recurrence, about a quarter of the ones that unobstructed did become re-obstructed in a median of about 2 weeks. So there was a time period of which they did unobstruct, but then quickly re-obstructed in about a quarter of patients. All of these notably were palliative intent patients. So the definitive intent ones, once they were unobstructed, they did not re-obstruct within that time period. And when they looked at time to unobstruction, definitive intent remained obstructed for about 8 days, but then did unobstruct. So they had a higher proportion that unobstructed, but it took longer. Whereas the palliative intent, they did kind of have a shorter response. So within 4 days, is the median by which they were unobstructed, but they had less respond overall, with only about 50% becoming unobstructed with palliative treatment. And again, as I mentioned, they used a lot of different treatments, but they noted one particularly called the quad shot, which is 4 gray, with 4 different fractions over 2 days. And that they noted that all of those had relief of their obstruction at about 2 to 3 days after treatment. So the quad shot of the palliatives, they did just kind of bring out in their article as one that might be more likely to unobstruct them, but they didn't really include it on whether they were part of the re-obstruction group or not. So after they didn't have relief of the urinary obstruction, which the 10 dogs did not, some of them were euthanized. And you can see that there was like multiple different, they were euthanized at different points of this. And sometimes before we would expect them to maybe be unobstructed by some. So, but this median of 9 days, that would have been after most of the ones with definitive intent would have already become unobstructed. And if they did have urinary obstruction relief, they did go on to complete their full course of radiation, whatever that protocol was. For survival of these patients, the event-free survival is on the top and the overall survival time is on the bottom. They did find 2 significant factors. So if they had definitive intent with adjuvant chemotherapy, they had longer event-free survival as well as a longer overall survival time than if there was palliative without chemotherapy. So definitive with chemo is better than palliative without chemo, but they didn't find significance between the other groups. They also tried to look at dose, where they looked at whether like the relief of obstruction was different between the dose per fraction and the total dose. They said this was regardless of what the intent was, which I find a little confusing just because that's like the dose per fraction was how they defined their intent. But if they did have an obstruction, if they had a lower dose per fraction, they were more likely to unobstruct, which kind of goes along with the definitive group versus the ones that had a higher dose per fraction. However, if they had a total overall dose, they were more likely to become unobstructed than if they had a lower dose. So a lower dose per fraction and a higher total dose will be more likely to lead to them becoming unobstructed than the opposite of that. When they looked at obstruction, there really wasn't a significant association of location on overall survival, event-free survival, or duration of obstruction. This is a different finding than before, where prostatic involvement was thought to have a reduced overall survival in prior studies. And this is just the representation of this, where they looked at all of the different factors, and none of them you can see on all of these charts where they look at location. They all seems to be a good amount of overlap between them, and this one's like they're basically all the same on the probability of becoming unobstructed, so that did not really make a difference from urethra, ureter, or urethra and ureter for whether they remained obstructed or not. So both urethra and ureter had equal ability to become unobstructed. Looking at adverse effects that they noticed from this, they did note quite a high amount had acute radiation toxicity, so over half of them did, and all dogs that had definitive intent did have acute toxicity, whereas about 40% of the ones that had palliative had acute toxicity. In dogs that received both radiation therapy and concurrent chemotherapy, they did note that there was a higher grade of diarrhea in these patients. And they did classify, even if they were on chemotherapy, if they had diarrhea, they would classify that as a radiation toxicity, even if it may have been due to the chemotherapy. For late effects that have been seen, it happened in about 16% of them. They were quite significant though, so about 12% of these, 12% had this late radiation effect that had a stricture and fibrosis. 2 were within the ureter and 1 was within the urethra, and it happened about 180 days post-treatment. They did not have histopathologic diagnosis for this, but it was diagnosed based on ultrasound, and there was also included in this, they noted that it was likely not due to progressive disease or from the tumor itself, because it did have characteristics that were not consistent with that on ultrasound, and sometimes was not in the region of where the tumor was, or the main tumor mass was. When they looked at the ones that had acute and late, if they experienced acute urinary effects, about 75% of those would have late radiation effects too. And they did say that there was no reports of urinary incontinence. So previously, urinary incontinence had been reported in about a third of patients that undergo radiation therapy, but they did not have any that reported urinary incontinence. And this is just a visual representation of what this adverse effects look like for both definitive and palliative. And as I mentioned, these are kind of the 3 main categories that we see for urothelial carcinoma. The majority of them did seem to be fairly mild grade, which the max grade of these acute was a 3. Sorry, over here. Max grade was 3 for these, which for the colon 1 particularly, which was the most common, grade 3, this is hemorrhagic diarrhea with tenesmus, but didn't require hospitalization. So not necessarily a life-threatening or highly, more of something that we would treat, but not severely affecting them. Looking at survival, their median survival was 134 days, and time to event was 107 days. You can see there's a wide variety here of overall survival and time to the event. They did note in these that this is lower than what's been previously reported, with like around 600 or 500 days with radiation therapy has been previously described for overall survival, but that this might be because the patient selection here is the ones that were already obstructed, and so those are likely the more severe cases of this disease. Looking at euthanasia, similar to other studies, the progression of local disease was the highest category for this, with metastasis being less, and then it wasn't documented in a lot of these when they were euthanized of what the overall cause was, so a lot of them were unknown. For survival, when they looked at what protocols and what had significance, the patients that had definitive intent and chemo did better than the ones that had palliative without chemo, but there was no difference otherwise in the other groups. But in addition, if they had palliative with chemo, and they did better than palliative without chemo. So basically trying to say that radiation therapy, if we do radiation therapy for these, it is helpful and improves survival if we also include chemotherapy in these patients. Despite the increase in overall survival, there is no difference between event-free survival with or without chemotherapy. And For this, the lung metastasis did do quite poorly. If they had lung metastasis, they only lived for about 20 days. If they had no metastasis, their median survival was around 135 days. So it does make a big difference in these and would be something to talk to owners about, that if they do have lung metastasis, which I think we already talked to owners about, that if they have that, then it's likely more progressed and severe disease with a lower response rate. They did mention, though, that with lymph node metastasis, this made no difference in survival. So it's mainly the lung metastasis that would be the concern. So what kind of some key points that I took away from this study was that there was overall a 60% success rate for relieving the urinary obstruction with radiation therapy. The definitive intent does have a higher success rate and increased survival with chemo, but they are obstructed longer, so they might need more hospitalization with UCAF placement, although maybe these are the cases where temporary urethral stents could be used for that period of time and then potentially removed. For the palliative intent, it had a quicker time to become unobstructed, so definitive intent was around 8 days, palliative intent was around 4 days, but it did have a lower event-free survival and overall survival when compared to definitive intent. This study, they did say that their overall survival was less than what's been previously reported, and this is likely due to the severe cases that they had where they were already obstructed by the time that they were diagnosed and being treated. If performing radiation therapy, if we do concurrent chemotherapy, this will increase the survival of these patients, and that the location, whether urethral or ureteral, does not affect the overall survival time or whether they'll unobstruct or not. The other thing to take away is that the acute effects does affect many patients, so about 50% or more, slightly over 50% will develop some sort of radiation toxicity in the acute setting. This was just a chart I made so that I could have this comparison of what the response rate is for all of these different options, and when we're thinking about incontinence rates and everything like that, when we're talking to owners. So response rate around 60%, NSAIDs alone has quite low response rate just when they talk about like whether there's any remission, which is mostly what that's talking about. Median survival, as most people know, it's like around 3 to 6 months for NSAIDs, but there's been a wide variety reported, 6 to 12 months with chemo and an NSAID, and radiation therapy has had quite these high numbers, but when they are obstructed, it is significantly reduced to 1/3. Looking at rates of reobstruction, or when I look at stent placement, which is the other kind of thing that we would do in these settings, or at least been reported and has some literature for it, is that they do have a low median survival. This is with stent placement alone, or like stent with and an NSAID, but if they add chemotherapy, they can live a lot longer, and kind of similar to chemo alone. They do have a significant risk of incontinence of about 1/4 to 1/3, which is, when reported, urinary incontinence was about 1/5 in these cases. So maybe a slightly lower risk, or it's a little unknown though, because it's only reported in one study and I couldn't find any reports in the other studies. So just something to keep in mind, that incontinence can happen with both RT and stent placement, maybe slightly less too in the radiation therapy category. When looking at reobstruction, importantly with radiation therapy, with these ones that did become reobstructed with palliative intent, it happened about 27% of cases and at 14 days, so quite a short time to reobstruction. Whereas if you look at stent placement, this is the metallic stents, it happened at about 16%, and it was a little bit longer at least, so probably a median around 47 days, but one did happen as early as 20 days when looking at that study. Looking at limitations of the study, I think it was a really interesting study, and I think it was great to show that radiation therapy can be used in these urinary obstruction cases, and helps think about like maybe we could place something like a temporary stent in the ones that are going to go for radiation therapy because they might become unobstructed. However, this study did use a lot of different protocols in both the chemotherapy protocols as well as radiation therapy. So it makes it hard to know exactly like what palliative intent might be the best option. Based on this study, maybe the quad shot where they do 4 fractions of 4 gray over 2 days would be the one that they found at least all of those dogs did become unobstructed, but it was such a low number of cases that it's probably hard to make that claim. It was kind of unclear the diagnosis of obstruction and relief of obstruction. So the obstruction they talked about, like there was clinical signs of like plaquuria and then diagnosed on ultrasound. I think that is true for the ureteral cases, but I think when we think about the urethral cases, a lot of time that's like a clinical or looking at post-voiding residual volumes or and that was not necessarily included. About 44% did have a urinary catheter in place, but it's a little unclear like what happened with the other obstructed ones. And then the relief of obstruction did talk about like owners talking about the relief of obstruction or the azotemia resolution, which may or may not show complete relief of obstruction in those cases. Another would be just something to think about for this case is that only about 40% had cystoscopy. So when we look at kind of the prior studies where they could have had a geographic miss, and so maybe this is why some of them didn't obstruct or became reobstructed shortly afterwards, is did we not do a large enough of a region for this to be effective in those cases? And then just in general, and I think is a problem with many studies that we do, but at least it gives us information out there, is that there was a limited number, and this is especially true for the definitive intent category, where there was only 6 dogs that went through definitive intent radiation for this disease. So just a limited number of cases to make conclusions on. My main takeaways from this is that RT can be considered for obstructed dogs with urothelial carcinoma. And if they don't want stent, then it would be something to consider. Or if they don't want a long-term stent, it would be something to consider for these patients. Dogs with urinary obstruction from urothelial carcinoma can be considered to have RT and will relieve the obstruction about 60%. But just keeping in mind that if they are doing definitive intent, it will be slower, but it will be more effective. Whereas if they choose palliative, it's got about a 50-50 chance that it will unobstruct them. The relief did become reobstruction in about a quarter of these cases. So I think that is something to consider as well when we think about RT versus stent placement, where stent might be able to have a longer relief of obstruction than radiation therapy, especially for the palliative intent approach. And this would be something that I think we should maybe have a multimodal approach to improve the obstruction and long-term survival. And kind of in general with these urothelial carcinoma cases, is maybe we should be using chemo and radiation therapy, even in these obstructed cases. So it's something to think about and talk to all the owners about. And overall, my other takeaway from this is that using CT and cystoscopy can allow for better visualization of what area to include for RT. So should we be working with our radiation oncologists to be scoping more of these patients to be able to define their target area better if they weren't scoped prior to diagnosis. So that was the study and kind of my takeaways, but I'd love to hear from you guys if you have any questions or comments about this study or what you're doing in practice with radiation therapy in these obstructed cases, if you have any anecdotal experience or anything like this.
Thanks, Nicole. That was really great. We don't have the ability to do in-hospital radiation yet here at Friendship. We have a LINAC in our new building, but our radiation oncologist hasn't started yet. So it's a conversation that we've had for some of these cases that, once we finally got RT up and running, is that something that we would use for the management of some of these cases, maybe avoiding urethral stenting, maybe for those cases that we didn't want to debulk, could those be good options for it? And I think reading this series and at all the literature that you did a great job reviewing, it's possible, but I guess I'm also not super excited about how effective it's going to be if we really get them coming in obstructed, as we so often do, and then that's our treatment point, and the goal is to get them de-obstructed and get them home with enough time that other meds can work. You know, for these patients in this study, how a number of them were already receiving chemo and whatnot. It might be maybe a little different for those patients that are therapy naive that come in, and the first time that we diagnose them is when they come in and they're obstructed and they haven't seen therapy. But it also just seems like it's a lot to go through, with the odds of there being reobstruction being fairly substantial, I think, for the cost and whatnot and the treatments that's going to go into it, versus the ease and certainly less cost than getting RT to do a urethral stent, and certainly debulking was another option that is more challenging, but probably even less expensive than a stent, because it's you don't have the hardware that's there. So I'm still questioning to when I would use this as part of my management in the dog coming in with obstructive carcinoma. I think for another means of therapy, sure, but as the approach to say, like, can we just use this to de-obstruct them? I'm not I'm not yeah, I'm just nervous that would be sufficient or provide enough long-standing effects that it's going to be what we need to bridge the gap for other therapies to take effect. So it was nice to go through all of this, but I'm still a bit unsure once we're up and ready to go how often I might turn to it versus what I'm currently doing now. And I don't know, kind of going along with your last question, I'm interested to see those people that have been doing it, like to what extent, how often they're using it and whatnot. I know Joe Barches mentioned that that they did it. I think they're doing it more often down in Georgia as a way to manage them rather than stenting them. And I don't know if they have results that are a little bit better, but I was just a little bit unimpressed by the outcomes for de-obstruction and the duration of being de-obstructed from this paper.
Yeah, I agree. I think the 8 days with definitive, which is the more effective option, I think that just is not very attractive to most owners, and would add a lot of cost to what we do too, is just the hospitalization time alone. So I do think that is definitely a huge limitation. I guess if they were really against a stent, or if you didn't have the ability to try debulking, it would be an option. But I think the hospitalization time, like, a lot of owners don't want to do that. And of course, we could place a temporary stent or something else to try and help with that. But I do think the time and the recurrence just gives me pause as well.
Yeah, I think for me, I'm probably still going to recommend it as a means of treating their disease with chemo, but not necessarily eager to employ it for de-obstruction in the beginning. Unless I'm going to do something else and they want to start right away, then fine. But probably not relying on that as the only means of de-obstructing, because I feel like those patients, even for the clients that are on board to do palliative RT, that's still a lot. That's still asking and a pretty big commitment. I feel like those people would also be fairly committed to doing other things, stenting of, if it's not a male dog, maybe even just ballooning the urethra, as that one study showed that was effective for non-prostatic obstructions as well too, like doing something else while doing it too. But I'm not sure how often I might be turning to RT as my sole means of de-obstructing for these patients.
Yeah, thanks, Nicole. I'm sorry my cell signal was cutting in and out at times, so I wasn't able to listen to all of it. But the other comment I would make is that, the owners that are willing to go for definitive intent and chemotherapy may be also more committed and less likely to euthanize quickly. I think we certainly saw that with our urethral stent cases. The ones that had already been on chemo for like a year, and then they obstructed and replaced the stent, they were more willing to do things. And I think the other thing is that, you have to look at how cultural norms affect choices for euthanasia. I look at that paper out of Japan and think, well, that's a culture that's hesitant to go with euthanasia. So if we look at survival times for ballooning alone in that study, I don't know how to interpret that relative to studies where euthanasia is a more acceptable, culturally acceptable alternative. That makes sense. So anyway, just a couple of thoughts.
Yeah, that's a really good point, Larry. I think I mentioned it at Lutz. I would not have guessed that balloon dilation would have been as effective as what they reported in that study, and maybe it is the tolerance. Maybe it helps and it gives the people more time to become comfortable and reset their expectations for what their dog's going to do, and maybe that's how they then they can live so long. I've only done it once, and it was for a dog that actually had prostatic carcinoma, and it didn't work. And I told them I didn't think it was going to work, and it didn't. And that was the only time that I've personally tried it. But it might be interesting to see for those clients that don't have financial resources to do much more, what the outcomes might be here for that type of procedure, and is it some of those cultural norms that are giving it maybe a better outcome than what we would expect? Because yeah, I'm still a bit surprised by the outcomes that they reported, and haven't done any other than that one patient to really have my own anecdotal experience to compare to it as well.
Yeah, my main experience with ballooning is more for proliferative urethritis, which is a totally different disease. But then the ones that we had a English Mastiff that had a massive prostatic. It was urothelial carcinoma, but was involving the prostate, and it was so firm it just crushed the stent. And then trying to balloon it open, even that wouldn't hold the tumor at bay with a self-expanding nitinol stent and a balloon. It was being crushed by the tumor, but it was like a 9-centimeter tumor in a 200-pound dog. So.
Now that we have a couple of radiation oncologists, we've been doing it more, and I'm not a big fan of stents and a lot of the complications that go with that. And the owners have been happy with outcomes, and I guess I've been happy with outcomes. I'm not sure how much longer we're expanding or extending their lives, but I have a feeling it's longer because they have yet another option to try.
Yeah, and I think when you look at this study over multiple years, what's being done currently with temporary radiation may be more beneficial. So having larger numbers done previously may be more beneficial. I'm talking to Allie Kendall. It sounds like they feel like their recent successes are greater, but yeah, we're not doing that currently, so. Which is more of an equipment and personnel issue.
Yeah.
Great. Well, yeah, I appreciate all of your input on this, and yeah, we'll see what happens in coming years. If it becomes more popular or not. I think radiation therapy in general for urothelial carcinoma is a great, like a great adjuvant option for everything else that we do. So, maybe we'll find more cases for this, or like JD mentioned, ballooning them would be a kind of an option with this potentially too, if it's as good as maybe that one study would lead us to believe. But thanks so much, everyone, for joining the discussion today.
Thanks, Nicole. Great summary. Really nice work.
Thanks, Nicole. Really good.
Thank you. All right. Have a good rest of your day, everyone.